I am Sultan Babar. I am a primary care sports medicine doctor at Lenore Orthopedics and Sports Medicine. Now, here we have a case. Same patient, EKG is done and reveals VFib. He has no spontaneous respirations. He has no spontaneous respirations. Shock, that is correct. Exactly. AED, defibrillation. Synchronized? No, unsynchronized. Because what are you going to synchronize it with? What are you going to synchronize it with? That's my question. We've talked about a lot of that other stuff on there. Yeah, with QRSs. But when we talk about the EKG, and actually, now of course, don't forget the common sense stuff to make sure it's powered on and all that stuff. And it has to be in more than one lead for you to be concerned about. Now, VFib, there's a good cartoon version of it. That's VFib. And we'll look at VTAC in a little bit. That's VFib. None of these are clear QRSs. Exactly. None of these are clear QRSs. So you can't synchronize. Unfortunately, you do have to remember that, because if you wait for it to synchronize, you're going to wait forever. You won't be able to get anything for it to synchronize with it. There's an EKG on there. Again, not all QRSs are about the same, especially if you guys see this lead right there. That is how the cartoon version is classically presented. I mean, some are tall, some are short on there. So that's your VFib, and you cannot synchronize on there. Shockable? We've already answered that question, and I think that was a resounding yes, right? That was a resounding yes. Is this shockable? I'll just put yes here. And what about meds? Actually, let's before we go to meds, if we say shockable, with what? That is correct. 120 to 200 biphasic or 360 monophasic unsynchronized defibrillation on there. Unsynchronized defibrillation on there. And if you don't know, just pick 200. Can't go wrong with that. Now, what about medications wise? What meds are we going to use in this patient? Amiodarone and lidocaine, yes, you can use those, but when you're going to do them, that's not immediately, especially when you're doing initially on there. And most of them are used for maintenance purposes more and more. They are starting to become less and less in favor. Epi is becoming more and more important on here. Epi is becoming more and more important on here. So there you go. There's your shock and there's your meds. And again, same protocol. Same protocol. Same protocol. Otherwise on there. So now same person with slightly little differences. And we're going to talk about this in a little bit more detail, because there are important things here that we need to start looking. You're going to start meds immediately if the shock is not available on there. Until you get that rhythm check and you have defibrillator available, you will give them that shock, and you'll still continue medications with there. So you'll give shocks and you'll give medications on there. But you will start with the shock. If they ask you what is most likely to convert that, and they give you both medications and shock, pick the shock. Pick the shock. For Medora, for maintenance purposes, the AHA does recommend using of amiodarone for maintenance purposes, but not during the initial CPR purposes of that. That is becoming falling out of favor, especially with recent research on there. So, same 50-year-old man falls and dies, but this time he is awake but disoriented and confused, complaining of dyspnea and lightheadedness. Exam reveals JVD and blood pressure is 114/80. This patient has VTAC. Why are the things that I have circled important in this case? What's important in that? Exactly. Exactly. I mean, you guys got it all. We're trying to see, is this patient stable or is this patient unstable? Why are we concerned about stability and instability? How does that affect anything? Not synchronization. Treatment, exactly, treatment. So that's going to be important on there. What things in the exam that is not presented here can be other signs of instability? Blood pressure, absolutely. Altered mental status, you got it. His blood pressure is fine, but everything else is in there. Blurry vision, shortness of breath. Once you guys are done, I'm going to put it all in one phrase. Chest pain, headache, absolutely. Pulmonary edema, yes, that's how they're going to get shortness of breath on there. End organ hypoperfusion. End organ hypoperfusion. That is going to be basically your signs up that this patient is unstable. Basically, they're sort of in a shock situation, Victor. That is correct. That they're not getting enough end organ hypoperfusion. They're not getting perfusion up here. They've got a headache. They don't know where they are. They're disoriented. They're not getting enough to the chest. They've got shortness of breath. They're not getting enough to the lungs. That leads to vasodilation. That leads to a pulmonary edema. And that leads to shortness of breath on there. Blood pressure is another measure of how good is the heart doing. All of those are sign of, okay, yes, the blood pressure is low, but blood pressure is a number. I'm concerned about, is this blood pressure enough? And all those things that we just talked about, answer that question. Is this pressure enough or is this not enough? So end organ perfusion. Other things to keep in mind that you're not going to see on exams but are important because they may give you this patient and say, which of the following lab abnormalities is likely to be present in this patient? If he was found like this, left like this for a few hours, creatinine is going to go up, right? Kidneys, hypoperfusion. Lactic acids going to go up, all right? Liver enzymes are going to go up, all right? Lactic acidosis is one of the types of metabolic. So yeah, metabolic acidosis, specifically lactic acidosis, that's going to go up. All those things are going to come in there. So it's not important to know the clinical presentation. Yes, in reality it is, but on the exam they may say, which of the following lab findings are associated with it? When studying, you may say, oh, it takes a while for the labs to do that. Yes, but this patient has good VP. Apparently not. He may have good numbers, but it's not enough. May have good numbers, but it's not enough. Somebody that wants to do a research residency just needs to pass the step 1. Somebody that wants derm, that's not going to be enough for them. Passing isn't enough for them. They need that 260 on there. Yes, numbers may be good, but not for his body. End organ hypoperfusion. Do we shock or do we cardiovert? That is the question that we're trying to get to. Do we shock or do we shock or cardiovert? Well, I mean, shocking is one of the ways of cardioverting. Would you shock this patient, assuming you didn't have any other means there? How many people would dump his? Yeah, so we got 1 no and 1 yes. Absolutely, absolutely yes. We will this patient does need to be shocked on there. So a little bit about the rhythm of the patient, and when we talk about the EKG, what we're going to look for is here. So the SA node, this, as you guys probably know, I'm going to go over this a little quickly. That is the pacemaker of the heart. If that fails, the ventricular node is a little bit, it's an AV node, has a slightly lower baseline rate. And one of the things it does is it slows it down. We're going to get to the treatment in just a little bit, and I want to talk about that formally as opposed to just give you guys bits and pieces of it here. AV node. And then it goes through, and the current travels through the heart, so that way the heart can beat in a synchronized manner. So that way we can get one big whoosh out there. That's why that QRS, is so narrow normally, because his Purkinje system is really quick at making sure it delivers the electrical current to where it needs to go. It is really quick at making sure that it goes where it needs to go. Now, with VTAC, that fails. You're not using the his Purkinje system. So what are you going to notice about the QRS complexes on the EKG when you have a VTAC? Exactly, they're going to be wide, because the rhythm origin, the V part of that ventricle, means that it is coming from somewhere in the ventricle. So that means it's starting somewhere here. Poor color choice. That means it is starting somewhere here and then taking its time and delivering it cell by cell by cell. Think about it. If the president had to send something out to the whole military, he can send out one order that goes everywhere, or he can tell one person, who can tell the next person, who can tell the next person. Think of it as the... Yeah, so basically tweeting would be the his Purkinje system, where anyone can hear it quickly, but if he just told one person and told the other person, think of that as if it's traveling through the myocardium. It's going to take longer, and hence the QRS is going to be wider on there. Hence the QRS is going to be wider on there. So we have 25-year-old medical student comes home after class, finds no messages on the answering machine from his girlfriend. In a fit of despair, he takes a bottle full of pills in an attempt to commit suicide. Changes his mind and wants to live after all. Walks into the ED 30 minutes after ingestion. So he wants to live, but he won't tell you the specific name of what he took. What's the next best step in management? What's the next best step in management? Right? Yeah, so pump his stomach, maybe. Gastric lavage, maybe appropriate. ABC, yes, absolutely important. Charcoal, if you get nothing out of the next 40 minutes, if you're about to sleep, charcoal. Remember charcoal. Yes, we're going to talk about charcoal. Yes, so all those things on there. So all of these are great answers. And now this vignette intentionally leaves off some of the important information. We don't know if this patient is stable. So people that said ABC, yes, that's an important part. People that says charcoal, we don't know what he took, but yes, charcoal's on there. UAN blood test, absolutely important on there. We don't even have a full exam on this patient. Yeah, exam would be nice if we actually had a physical exam on there. So this leaves off. And the purpose of this vignette is to get your gears grinding. What are you going to do to be able to do that? What are you going to do to be able to move on with that? And you guys have all answered things that are important on there. And that's one of the reasons I opened that on there. Yeah, we don't even have a great history on there. We're not saying what symptoms he's got or anything like that. So it's missing a lot, but that's where you guys are thinking. Oh, this question is not geared toward an answer, but geared towards thought. So you guys have thought of all the things. So here's what you need to do. Initial evaluation, you got to find out, what did they take, right? What is the nature of the toxin? What is this patient taking? How long has it been since they took it? Does the treatment differ from someone that came in 15 minutes after taking a bottle full of Tylenol versus someone that says, oh yeah, I forgot about it, but 2 days ago I took Tylenol? Yeah, you bet it matters. So timing is going to be important. So that's there. And the way they're going to ask you, which of the following is an important determinant in the survival of this patient, in the long-term outcome of this patient, in the treatment of this patient? And we'll talk about when that becomes a nature on there. History and exam, right? To look for that. Is the patient alert, awake, alert, and oriented? How was the patient found? And some people say UAN blood test. Absolutely. You were going to do tox screens, toxicology screens on there to see, well, what do the blood results show? What do the blood results show in these people? Now, when we talk about symptoms associated with that, every single toxidrome, every single medication has certain amount of symptoms that are associated with it. You're not required to know all of them, but you are required to know some of the common ones. So here begins our onset of lists on there. But before I go, let me give you guys another tip on how to remember this stuff. All the drugs of abuse, I want you guys to think of them in autonomic terms. Is this sympathetomimetic or sympathetolytic? Is this cholinomimetic or cholinolytic? Is this going to be parasympathetic or sympathetic response? And once you get that, the toxidrome becomes easy to remember. And then you can add on your little, caveats to that and say, well, this is how we need to go ahead and treat that better on there. So, well, this is what we need to do and this is what it is. And not only that, it'll also help you remember the withdrawal of that. It will also help you remember the withdrawal of that. So here's one of your first questions on there. One of your first lists on there. So meiosis, if you have that, medicines that cause that: clonidine, barbiturates, opiates, pontine stroke, and cholinergics. These are the medications that are going to cause meiosis. The opposite of that, mydriasis, you have cholinergics here, you have anticholinergics here. You have cholinergics here, and you have anticholinergics here. So cholinergics there and anticholinergics there. Other thing, opiates here and sympathetomimetics here. Opiates and sympathetomimetics, you know, opiates are downers, sympathetics are uppers. Downers versus uppers on there. So that's one thing on there. The other thing that we got to remember is here's where it becomes a little bit complicated. Remember I said they're all not going to fit in. In some places you will have to remember the caveats on how to change that. Dry skin versus wet skin. Sympathetomimetics are going to have mydriasis and wet skin. Cholinergics are going to have meiosis and wet skin. Anticholinergics are going to have mydriasis and dry skin on there. So with the eyes, with the skin, it becomes a little bit difficult on there. Remember this: barbiturates and blisters, barbiturates and blisters, barbiturates and blisters, barbiturates and blisters. No, I'm not having a vocal seizure or a verbal tic on there. I want you guys to remember that. And we'll talk about a couple of other things that it is easy for them to put together a question about barbiturates on there. It is easy for them to put the question on there that not a lot of people questions will get that question right. So barbiturates and blisters, keep that in mind. Now some of you guys are going to have bad dreams about me where I'm going to be saying barbiturates and blisters. So now other things on there that we talk about, some of you guys mentioned gastric emptying. Yeah, timing's gonna be important on there, but gastric emptying may be an option that we can use. And we'll talk about some of these options and when we consider gastric emptying an appropriate thing. Um, First things first, induced vomiting with ipecac, always the wrong answer. Always the wrong answer on there. One of the first things that I said was charcoal. If you get nothing on there, if you get a toxicology question and you can't make heads or tail out of it, and you see charcoal as an answer choice, it's a good bet. It's a good bet. It is a good bet on there. Um, Whole bowel irrigation, that may be needed on there. Dialysis, we'll talk about indications for that. Cathartics, forced diuresis, and other things on there. Anybody that comes in comatose, do that. Answer choice A is naloxone. B is dextrose. C is thiamine. Which one are you going to do first? I can put them as slash slash slash. Exam will put them as A, B, C. I see between naloxone and thiamine. Naloxone is correct. Thiamine would be next. But thiamine always before dextrose. That is correct. Thiamine always before dextrose. And if they're comatose, if they ask you what's the next best step, and those are options on there, naloxone first.